Now, this is the talk about sickle cell disease. So I signed up for this talk because we don't see very much sickle cell disease. So has anybody seen a case of acute chest syndrome in here? Only one person? Okay. All right. So then this is going to be important because you may not actually see this in vivo. So you need to learn this some way because many of you will go to hospitals where there will be more patients with sickle cell disease, and you thus need to know how to manage them. So what we're going to do is we're going to go through two cases. I'm going to have one that's a little bit more basic. That's going to be for an intern. And then I'm going to have one that's a little bit more advanced for a second or third year. And then I'm just going to go over some general pearls about sickle cell disease. So before we begin with the cases, actually, a little background terminology. So if somebody says they have sickle cell disease, what that should mean is that they have 2 copies of an abnormal gene, abnormal hemoglobin. So sickle cell disease is recessive. You learn that in medical school. And so oftentimes the patient or a hematologist will refer to it as hemoglobin SS because they have 2 copies of the sickle cell gene. So there are other versions of this, namely sickle cell trait, which is abbreviated HBAS. The A is the normal hemoglobin, hemoglobin A, and then the S again is the sickle cell. So this patient is recessive. You will see these patients. In general, these patients are not sick. They don't get pain crises. They don't get acute chest syndrome. They don't get other manifestations of end organ damage. Although it is possible in certain extreme situations that they can. For example, if they were like climbing a mountain, or in some severe case of septic shock, they might manifest some sort of sickle cell pathology, but vast majority of the time, this patient is not sick. If you see a patient who has sickle cell trait who is claiming that they have a pain crisis, they're probably drug seeking. And if you work in an inner city place with a lot of sickle cell patients, you will actually see that exact case, is a drug seeking sickle cell trait patient. Other variations of abnormal sickle cell patients. So hemoglobin SC, that is something that you will rarely see unless you're a hematologist, but that is another type of abnormal hemoglobinopathy. So they have 1 copy of a hemoglobin S, part sickle cell, and then hemoglobin C is another type of abnormal sickle cell. So these patients are kind of in between the level of sickle cell trait and classic sickle cell disease SS. Similar case with HBSO. Again, 1 copy of the abnormal sickle cell, 1 copy of O is another abnormal hemoglobin, and S beta stands for beta thalassemia. So these are all heterozygotes that can be sick. The reason it's important to understand these things is that there is this spectrum from sickle cell trait to not sick to these heterozygotes that can be sick up to the classic sickle cell, which generally are sick. And so when someone says they have sickle cell, you should specify what type of sickle cell exactly. All right, so we get to case 1. So I forgot to bring my prize today, so you are volunteering for free and you're going to be on the internet. So you need to have some balls or guts if you're a female to volunteer. Ovaries, yeah. So intern, want to solve this case? Rich always volunteers. Where are you? All right, there you go. All right, Rich. It's not that bad, trust me. This is a 16-year-old male with sickle cell. He presents to the ED for pain in his bones for 24 hours. In particular, his back, right thigh, and left hand hurt. He's had similar pain in the past with pain crises. He gets pain crises 3 to 4 times per year. He reports 3 days of runny nose and generalized weakness. That should give you the vast majority of the information you need, Rich, but is there any other questions that you want or anything you want to clarify? Okay, all the relevant symptoms are here. All right, great question. So the question was, does he have a hematologist? The answer is He has a hematologist, but he doesn't go very often. He doesn't. He's not good with going to his appointments. All right. So the question is about other prescribed medications, and the answer is that he thinks that he was given something else in the past that started with an H, but he doesn't take it. And anybody know what that's supposed to mean? All right, good. Yeah. So a patient like this should be on hydroxyurea. If somebody's having multiple pain crises per year, they should be on hydroxyurea. And then, actually, just coming out last year in the New England Journal of Medicine, glutamine. You may see this in the future. You're not going to prescribe it as an emergency physician, but you may see that people are on it. Sickle cell patients with bad disease probably would benefit from being on glutamine as well as hydroxyurea. All right, so he's not on any real sickle cell medications. He's just on the pain medicine. All right, so we're going to move on. So here's the exam. These are the vital signs. As you see, they're basically normal. And frankly, the physical exam is generally normal. In general, he doesn't look like he's in any distress at all. He's texting on his cell phone. And then you look at the areas in particular. He said his back hurt. Back looks fine to you. You look at his extremities, his thigh and his hand, where he said it hurts, and those also look fine. They're not swollen or anything. So, Rich, is there anything else that is pertinent to you on the exam that you want to know about? No, his neurologic exam's normal. And in fact, anything else that you want to ask about, it's all normal. So, all right, so we'll just proceed to, what do you think the most likely diagnosis is at this point? And then second question, after you answer the first question, what do you want to order? So what do you think the most likely diagnosis is, Rich? Okay, so you say acute sickle cell crisis. I would change what you said just slightly to... So, all right, very good. So Maldonado says pain crisis. All right, so very good. Yeah, so a pain crisis, an acute sickle cell pain crisis would be the correct diagnosis here. All right, we'll talk about how there's some varying terminology, and maybe if you say acute sickle cell crisis, people would understand what you're saying, but I think that you need to say pain crisis if you're going to use that terminology. All right, so then at this point, what do you want to order, Rich? No chest pain. He has no chest pain. All right, so your final answer, CBC, CMP. Flu swab? You want to do a flu swab? Is that what you're saying? Okay, flu swab. All right. And do you want to do the EKG and chest x-ray or not? Okay, so you're going to do a CBC, a CMP, an EKG, a chest x-ray, a flu swab. Are you going to do anything else? These are all your orders. All things that you're putting into the computer. All right, so Capelli says reticulocyte count. All right, what are you looking for with that? Okay. So Capelli says reticulocyte count to look for aplastic crisis. All right, not a bad idea. Gomez? So ESR and CRP, just so that you confuse the picture with excess slabs. I like it. All right. I'm messing with you. All right. I think that's good enough. But I was trying to also get you to say what else you want to order besides diagnostic tests, Rich. Yeah. Okay. Normal saline. How much? 1 liter of normal saline. Okay. What else? Okay. Okay. You can't order some sort of pain medicine in the computer. It's not an order. Fentanyl 25 micrograms. All right. A little bit of a small dose, especially for somebody who's on oxycodone at home, but I like what you're doing. All right. So you're going to give them an opioid. All right. So I'd probably give them a higher dose than fentanyl 25, but we're going to talk in more detail here in a second. But okay, very good. You got most of what you needed to get there. I like that. So, this is indeed a sickle cell pain crisis. There are some people who will tell you that it's better to call this an acute vaso-occlusive pain event. The reason that some people don't like calling them pain crises is because it's often not a crisis. That makes it sound way worse than it is. Usually they're just having some pain, but they're not in a crisis. So what exactly is causing this crisis? So at the very small blood vessel level, the sickled blood cells are blocking off the blood flow and causing some local tissue ischemia. So this is in fact an ischemic pain and hurts a ton as a result. There are many things that you can do to treat their pain. You can give them NSAIDs. You often have to give them opioids, and some people will even give them like a PCA morphine because they require so much pain medicine. Some people may tell you not to give them NSAIDs because sickle cell patients can have problems with their kidneys, and certainly they can have problems with their kidneys, but totally it is fine to give a sickle cell patient an NSAID. Do not be scared to do that unless like they have a known history of chronic kidney disease or something. And in particular in a kid, I think it's a very good idea to give them an NSAID like Toradol. I have cited a study here that's not that great from pediatric blood cancer. The reason I cite it is not because it's the best study in the world, but because I like the idea of the study. The study compared intranasal fentanyl to placebo and in pediatric sickle cell patients. Their outcome was pain score after 20 minutes of placebo versus fentanyl. Not surprisingly, if you give fentanyl instead of placebo, the pain scores go down. So not an amazingly surprising study, but I like the idea of using intranasal fentanyl in pediatric sickle cell patients, which is why I bring it up. So intranasal fentanyl, anyone ever used it here? Yeah, you can't in Kendall, right? So the reason that you can't use it in Kendall is because you need this device, all right? This, at the tip here right there, the syringe is called an atomizer, so you can try it. But it's pretty easy to use. So what you're going to do is you're going to take 2 micrograms per kilogram of fentanyl. That's the dose, 2 micrograms per kilogram of fentanyl. And you're going to split that dose in half, so it's 1 microgram per kilogram per nostril. You fill up the syringe, you spray into each nostril half of the 2 micrograms per kilogram. In other words, 1 microgram per kilogram in each nostril. The device at the end here allows it to kind of spray into the nostril. That's the point of that device. All right? And it works very well. And in fact, other pediatric centers use this intranasal fentanyl for all sorts of things for kids, like if they have a bad laceration and you want to just chill them a little bit, or if the kid has a fracture but you don't want to put an IV in and sedate them, then intranasal fentanyl is a great means of getting pain medicine. And additionally, if you had a sickle cell patient who has really hard IV access, which is often the case, intranasal fentanyl, great way to get them some pain medicine, at least until you can get an IV, or maybe you try not to get an IV at all. Okay, any questions about that? So, yeah, on the internet they're like $10 per atomizer or something like that, $12 per atomizer, which is ridiculous for what it is, but yeah. All right, so a couple other things about pain crises. This is a thing not to do. Don't transfuse them. Don't transfuse them unless they have another reason to be transfused. And in general, in these patients, symptomatic anemia is the main reason to transfuse the patient. Do you give fluids to a patient with sickle cell pain crisis? Rich said he wanted to give this patient IV fluids. And the answer to this question is probably yes. So the reason I say probably yes is you might have a sickle cell pain crisis that's not that bad that you might not even want to put an IV in. If it's just a straightforward sickle cell pain crisis, there's nothing concerning about it, it doesn't seem that bad, maybe you use other means to control their pain and you can discharge them with no IV, no labs. That is a reasonable approach. But if it's bad enough that you're getting labs, you're putting an IV in, I say give them fluids. Now, what is the evidence for that? Frankly, there is none. There is a Cochrane review from 2015 that looks at fluids in sickle cell, and their conclusion is they don't know much of anything about what the use of fluids is. They don't know if PO is okay versus IV. They don't know how much. They don't know anything other to say that most people seem to give fluids. So the general practice is to give fluids for these patients. We don't know if that really makes a difference. We don't know how much to give. But my practice, like what Rich suggested, would be if I'm putting in an IV, just give them a liter of fluids. The idea is to kind of like dilute out the sickled cells. So it makes sense, at least theoretically to me, that it might help. The bottom line when treating a sickle cell pain crisis, just treat their pain. That's the main thing that you have to do. The fluids is really just about treating their pain as well. So if you can treat their pain, you can make them comfortable, they can be discharged. Questions about sickle cell pain crisis? Yeah. Yeah, I think that's a great plan. So Pavel's question for the recording is, do I set expectations about how much pain medicine early on with the patient? And I think that's a great plan. I think that if you're having to repeat multiple doses of narcotic pain medicines, you're probably just going to have to admit them. Now, I don't necessarily, in my mind, have an exact algorithm for that, but you will see sickle cell patients who will come in and kind of tell you specifically what has worked for them in the past. And as long as I don't think that they're trying to scheme on me, then I'll basically just do what they say, and then ask them after I give them what has worked for them in the past, like, do you feel like you're good enough to go home, and sort of let them drive the care for their pain management. Let's move on. So when you see somebody with a pain crisis, the question that you should ask yourself is this not a pain crisis? Is this osteomyelitis? So the question then is, how do you distinguish osteomyelitis and a pain crisis? And it turns out that there are some clinical factors that are very good at helping you distinguish them. So this is based upon a study from 2009 where they looked at clinical factors that distinguished osteomyelitis from pain crises, and the 3 factors that were the most helpful were as follows. Number 1, single site versus multiple sites. If somebody has isolated pain in one site, that's more concerning for osteomyelitis. So for example, in the case that we have at hand, he has back pain, thigh pain, and hand pain. Multiple sites like that, not likely to be osteomyelitis. Osteomyelitis is not going to probably cause pain here, there, and everywhere. Just one site. Similarly, with osteomyelitis, you're more likely to see swelling, physical evidence of something going on. In sickle cell disease, you're less likely to. That being said, you absolutely can see swelling in sickle cell disease in some cases. So you can't hang your hat on that completely, but if you see swelling, increase your suspicion for osteomyelitis and not just a pain crisis. And then finally, fever. This one's probably obvious to you. Somebody has a fever, you should suspect that's not just a normal pain crisis. You're dealing with something more, in this case maybe osteomyelitis. All right, let's continue. Back to the case. So you ordered other labs in addition to these. These are the ones that are relevant. Your LFTs, your EKG, your chest x-ray, and your flu swab were all normal, okay? So, but I've got your CBC, your basic metabolic panel, and your reticulocyte count well ordered by Capelli here. So Rich, how do you interpret what's going on here? All right, very good. That's what you were supposed to get out of this. So this here is suggestive of an aplastic crisis. Why? If somebody's anemic, their reticulocyte count should go up. It should go up because your reticulocytes should go up if you're trying to make new red blood cells. Your body should be trying to make new red blood cells when you're anemic. If not, something is going on in the process of making those red blood cells in your bone marrow. So this patient, in fact, does have an aplastic crisis. So you already got the answer to the question there. What is the additional diagnosis? The question now is, what do you want to do now that you think he also has an aplastic crisis? Okay. Well, we're going to admit him now. I like that. Okay. So what specifically do you want to order when you say you want to order blood products? All right. So Rich wants to order 1 unit of packed red blood cells. I would definitely transfuse this patient. You could start with ordering 1 unit. I say you're probably going to have to order at least 2 units probably in this patient. But yeah, 1 unit of packed red blood cells is a correct answer. All right. So blood transfusion of packed red blood cells is the correct answer here. All right. Just kind of a fine point. This patient has an aplastic crisis and has generalized weakness. I don't know if you noticed that. He has a symptomatic anemia, but the hemoglobin levels of transfusing always when you're less than 7, like kind of like we apply to the general population, you may not necessarily apply to a sickle cell patient. If you have a sickle cell patient whose hemoglobin is 6.9 and their baseline is like 7.5 or something, and they don't feel symptomatic, you don't necessarily need to transfuse that patient, okay? So over transfusing sickle cell patients actually causes harm. It leads to iron overload, which is a real cause of mortality and morbidity in sickle cell patients, and leads to them having transfusion reactions and making it harder to give them blood when they actually need blood. So if you ever see a patient who's like totally fine and they have sickle cell and they're just like they're pretty anemic, but they don't seem to be symptomatic from it, you probably don't have to transfuse them. All right. In this case, yes, we are transfusing this 5.2 with generalized weakness and an aplastic crisis. All right. So a couple other things about aplastic crisis. So it's generally triggered by infection, and the one that often shows up on your in-service and might show up on your boards, Rich, is parvovirus B19. So when I learned about this in med school and residency, I kind of thought like it was just one of those stupid things that you memorize for tests. And to some extent it is, but that being said, this is a real thing. This is a real thing, and this was demonstrated in a study from Lancet in 2001 where they followed 280 patients with sickle cell disease, and about 3/4 of them seroconverted for parvovirus B19, meaning that they got exposed to it. And of those that seroconverted, 2/3 had an aplastic crisis. So this is a real disease actually caused by parvovirus B19. It's not just one of those random things that you memorize for tests. You're probably not going to send off the parvovirus titers very often in the emergency department, but the connection here between parvovirus B19 and aplastic crisis is strong. You had a question, Colin?
Yeah, this is seen
Yeah.
primarily in the pediatric population, right?
It is, yeah. So by the time the sickle cell patients get to be adults, they've likely already seroconverted for parvovirus. So you're probably not likely to see this when they're an adult. That being said, a young adult, you certainly could still see this. I mean, you could see it in an old adult, but 3/4 or so of the patients have already seroconverted by the time they become adults. So the vast majority of the time is when patients are pediatrics. How do you actually diagnose an aplastic crisis? Rich did it perfectly. So the key here is that you need a low reticulocyte count, and it's going to be less than 1%, and that's going to be associated with an acute anemia, acute drop in your hemoglobin. Do you need to order a reticulocyte count on every single sickle cell pain crisis? Probably not. Frankly, you probably don't need to get labs. If there's nothing suspicious about the patient at all, they just say, I have pain that's exactly like all my pain crises before, and I have nothing else new going on. The patient probably doesn't need labs. In our system, you probably get labs, and you can get a reticulocyte count if you want, but you don't really have to. Now, the case here I designed to have the patient have this other generalized weakness symptom, all right, that was supposed to tip you off that something else might be going on. In this case, it's because he also had an aplastic crisis in addition to his pain crisis. All right, so very good, Rich. You survived case number 1. I now need a second or third year to do case number 2. Pavel, all right, this is your late wedding present. All right. So this is a case of a sickle cell patient with chest pain. 22-year-old female with hemoglobin SS presents to the ED for pain. That should say her right arm for 3 days and central chest pain that has developed over the last 24 hours. She also reports some shortness of breath. Past medical history is sickle cell disease. She is actually taking hydroxyurea. She's got no allergies, doesn't smoke, drink, or use drugs. Anything else you want to know about this patient, Pavel?
Some of the things, does she take anything or still take anything besides the hydroxyurea pain medicine?
No, when she gets a pain crisis, she's pretty good at managing it just with over-the-counter pain medicines, actually. She takes Tylenol, ibuprofen. The question is, does she see a hematologist? And yes, the hematologist is the one who prescribed her hydroxyurea.
Okay. And then anything else and any other associated symptoms, or is pretty much what's in the HDI?
Question, any other associated symptoms? The answer is no, not that she's noticed.
No
Yeah.
cough, no fever.
She hadn't noticed a fever at home.
Okay.
She hasn't had a cough.
Has she had this happen before?
No recent long travel
And no recent hospitalization?
and no recent hospitalizations.
Okay.
You good? Okay. Yeah. No, you got everything there. All right. So we're going to move on to the physical exam. Unlike the last case, this case, patient's vital signs are not normal, as you can see there. He's got a fever, tachycardic, tachypnic, and hypoxic. Here's the rest of the exam. The portions in red are the abnormal. She's mild respiratory distress. She's tachycardic. She's got an abnormal lung exam. Anything else that you want to know, or is that enough information for you? Okay. All right. Let's go on. So at this point, what's the most likely diagnosis?
Acute chest syndrome.
All right. So why do you think it's acute chest syndrome?
So patients with known sickle cell disease, onset of either chest pain or shortness of breath with suspected infectious cause in the chest usually is acute chest syndrome.
Okay. Very good. Yeah. So the constellation of sickle cell disease, chest pain, and respiratory symptoms, infectious symptoms does indeed suggest acute chest syndrome. So what do you want to order, Pavel?
So lab-wise, give her steroids and see what her labs look like to see.
Okay.
Start
All
with
right.
that.
Okay.
Supplemental oxygen, IV fluids.
All right. Yeah. I might have forced you to do too much all at once, but you've got pretty much everything there. So he said he's going to order a CBC, a CMP, a reticulocyte count, a chest X-ray, an EKG, antibiotics for pneumonia, so it'd be ceftriaxone and azithromycin. Will that work for you? Okay. Duonebs. Why are you giving steroids? You mentioned steroids. I didn't understand that part though.
That probably like the one I wasn't really sure about. I don't know if it would really help them. They're not a COPD patient, and it's but on the chance.
Okay. All right, we'll talk more about the treatment for acute chest syndrome here in a second. Here's your chest X-ray. So this, I'm gonna not even make you read it. Obviously has a opacity in the right lung, which could be pneumonia, but in this clinical situation, we would call acute chest syndrome. And that's because this is how you define acute chest syndrome. You have a patient with sickle cell disease who has a new opacity or radiodensity on chest X-ray accompanied by fever or respiratory symptoms. So in other words, it's something that looks just like pneumonia, except that they have sickle cell disease, and that's going to be acute chest syndrome. So why and how does this occur? Well, again, kind of like the pathophysiology for pain crises, you have these sickled cells that are blocking small blood vessels, and they're blocking it within the lungs. Although this is often triggered, and this is kind of weird, by actually something going on within the bone marrow that triggers fat emboli to go to the lungs, which then triggers the sickle cells to sickle. You don't really necessarily need to fully understand that. It's just kind of a strange pathophysiology that I thought we should mention. Oftentimes, in fact, the patient will start with some infectious process and may actually have pneumonia, and the pneumonia can thus trigger more sickling of cells within the lungs. So although the patient could theoretically have pneumonia and not a lot of sickling in their lungs, pneumonia and acute chest syndrome are not essential to distinguish. You basically, in a sickle cell patient with what looks like pneumonia, you're going to treat them like they have acute chest syndrome. This is important. So patients with acute chest syndrome often are also undergoing a pain crisis at the same time. So that's why I had in this case that the patient had arm pain. She gets that a lot. She doesn't normally get the chest pain. And many, if not almost all the cases of acute chest syndrome will start with a pain crisis and then progress to an acute chest syndrome. So watch out for that. So here are the labs on this patient. Yep.
I do know, I think this is the leading cause of mortality.
Yep. All right, so yeah, so that's a good assessment. So this patient, compared to the last, so this patient's also anemic, but this time the reticulocyte count is elevated. So that is appropriate. That's what's supposed to happen. And you notice the other abnormal labs, which are just suggestive of patient being sick. The creatinine is elevated, the lactate's elevated, the white count's elevated. All right, so we reassess the patient. She has already gotten the antibiotics that she wanted, but now she's unfortunately becoming somnolent and increasingly hypoxic. So what would you like to do at this point?
I mean, if she's still able to, depending on how difficult her is, they could try BiPAP in
Okay.
that patient, but if they won't be able to tolerate, might need to be intubated.
All right, so yeah, that's correct. You could do BiPAP or you could just intubate her. And we'll just say that you decide to intubate her and you intubate her successfully, because that's not where I'm going with this. There's something else that's important that we need to talk about here. So you intubate her, and now what else do you do after that?
Chest X-ray after intubation.
Okay, and chest X-ray still shows opacity. Actually, now looks a little bit worse even than before. Yeah.
Make sure your
Vent settings are all appropriate. So you've given her antibiotics, you've given her duonebs, you've intubated her. What other treatments might you consider in this acute chest syndrome patient? Aha! Anna and Pavel got that. All right. Okay, so this is one of the key points of the lecture here. This is a treatment that you don't give for much else, okay? We'll talk about the couple other times that you might consider it, but you need to consider an exchange transfusion. I'll talk about that in a second. So let's go just generally how to treat acute chest syndrome. So Pavel got this, antibiotics. So the antibiotics you're going to give, just act like it's pneumonia. Assume it's pneumonia and give whatever you would normally give for pneumonia. So ceftriaxone and azithromycin is kind of your standard community-acquired pneumonia. It's totally fine to give. And again, if the patient had like hospital risk factors or was like particularly sick, you could broaden those antibiotics. That would be fine. Consulting hemonc. Okay, so this is a hematology emergency. So this patient should have a hematologist helping you with the care. If you work somewhere that does not have a hematologist, you should transfer this patient. This is a true hematologic emergency, and the primary reason is that they might need an exchange transfusion, as we'll get to in a second. Before you do an exchange transfusion, another treatment that you might try, and probably should try, is just a simple transfusion. So the idea is to give them blood that doesn't have sickled red blood cells, has normal red blood cells, and having that blood will dilute out their sickled red blood cells and hopefully improve their symptomatology. So again, let's say you're working in the middle of nowhere and you're the unlucky person who gets a acute chest syndrome in some rural area, you don't have a hematologist and they're super sick. What you should do is start a simple transfusion. Give them 2 units of packed red blood cells. All right? That will help them, and then you should transfer them to somewhere that has a hematologist. This is not based upon evidence, but you should probably aim for a hemoglobin of about 10. That's what expert opinion would say as far as how to give a simple transfusion to an acute chest syndrome patient. And then for severe cases, this is not super well defined what severe is, exchange transfusion. Certainly if you are putting the patient on, or if you're intubating the patient, that's severe. If the patient's in like septic shock, that's severe. So there's some gray area there where the patient's like in a little bit of respiratory distress or a little hypoxic, but they're not that bad. You might not necessarily need to do an exchange transfusion, but you should consult a hematologist and then let them decide on the gray area. If the patient's as sick as the one in this case, that's definitely going to get an exchange transfusion. If the patient's chilling there with completely normal vital signs, you probably don't need to do an exchange transfusion. Okay? Yeah, Jesse. All right, let's talk a little bit about exchange transfusion. What does an exchange transfusion mean? An exchange transfusion means this. You take out the patient's blood, because that patient's blood is sickled and bad, and you replace it and you give them a blood transfusion. You see how that works? You're doing a transfusion, you're exchanging their bad blood for good blood. That's exactly what an exchange transfusion is. All right? We'll talk about another indication for it later. Does anybody have any questions to this point about that? Okay, very good. So this is the last section of the case. Pavel survived. Good job, Pavel. The sickle cell pearls, just a few other things that you need to know about sickle cell. So stroke. Stroke and sickle cell, different than other strokes. All right? So consider a case, 20-year-old male with sickle cell disease comes in with right hemiparesis. What do you do for that patient? All right. Do not give that patient TPA. Do not give that patient TPA. Do not give that patient TPA. If you want to kill that patient, give him TPA. If you don't want to kill that patient, don't give him TPA. All right? You get into a little bit of a tricky situation if you have like a 70-year-old male with sickle cell disease who comes in with right-sided hemiparesis, because then it's possible that they're having a stroke that's not from their sickle cell and is from normal causes of stroke. And that would suck if you had that patient. I don't know what to do. Tried still not to give TPA because I don't like TPA, but that would be a much more complicated situation. But a young person with sickle cell disease who has a stroke, their stroke is likely due to sickled red blood cells blocking the blood vessels, not a blood clot. So you give TPA, it doesn't do anything for a sickled red blood cell blocking the blood vessel. It only helps if there's a blood clot there, right? So you do not give them TPA. What do you do? Pavel got this one. You do an exchange transfusion. So again, if you see a patient who has a stroke syndrome, who has sickle cell disease, you get them an exchange transfusion. If you work somewhere that doesn't have a hematologist, you transfer them immediately. If you work somewhere that doesn't have a hematologist, you can also give them a simple transfusion. All right, you just give them 2 units of packed red blood cells, or if they're a pediatric, a weight-based 10 to 15 cc's per kilogram of packed red blood cells. Okay? So, questions about a stroke and a sickle cell patient? No. Infections in sickle cell patients. I was told by a pediatric EM physician who I respect a lot that every single sickle cell disease patient who comes to the ER with a fever, you should admit. And I say almost never is anything 100%, and that's probably not 100% for me either, because if someone has like an obvious just cold, then I don't necessarily think that I'm going to admit them. But I would say that's a general good rule of thumb. If you have a sickle cell patient with a fever, the vast majority of the time, you should admit them. Give them a dose of antibiotics and admit them. Why? Because they're at risk for weird infections. So encapsulated organisms, which the med students probably can remember the encapsulated organisms better than I can or the residents can, but it's like Neisseria meningitidis, H. influenza, strep pneumo. They are more likely to get all of those infections because they are functionally asplenic. Sometimes sickle cell patients have had their spleens removed, or sometimes if they haven't had their spleen removed, their spleen just doesn't work because it's been infarcted over time by sickle cell. Sickle cells blocking off the spleen, leading to successive infarctions, and they don't have a functioning spleen. So they're at risk for encapsulated organisms as a result of that. And this one is the weird one that I don't fully understand. They get salmonella infections. Sickle cell patients get salmonella infections. And in fact, we talked about osteomyelitis earlier. Most common cause of osteomyelitis in a sickle cell patient? Salmonella. Shows up once in a while on boards, not so much on emergency medicine stuff, although certainly could be possible. I would remember it just in case. All right, salmonella, most common cause of osteomyelitis in a sickle cell patient. That's a study that just says basically that salmonella is a common cause of osteomyelitis in sickle cell patients. Last part here, splenic sequestration. Somebody tell me what splenic sequestration is? Nobody knows, huh? All right, very good. So Colin says your spleen consumes all your red blood cells. Exactly. So for some reason, in little kids, their spleen grabs all their red blood cells, and all the red blood cells are in their spleen instead of going to the rest of their body, and so they get an acute anemia as a result of that. This is generally in little kids, like 2-3 years old, but could happen in a sickle cell disease patient at any age. What are the symptoms? They're going to have abdominal pain generally, possibly a palpable mass if you're good at feeling a spleen. These patients will have a huge spleen, so you probably can feel it even if you're not good at feeling a spleen. And they're going to have symptoms of anemia. They might be generally weak, fatigued. They might look lethargic. They might be pale. They might be hypotensive, tachycardic, all of those things. How do you diagnose this patient? So this is going to require you to realize that something's going on in their spleen. They may have tenderness in their abdomen. They may have a large spleen. They may have increased reticulocyte counts. And again, if they have low reticulocyte counts, maybe the cause of their anemia is something else, like an aplastic crisis. What do? You transfuse them. This will be just a simple transfusion, not an exchange transfusion. You're just giving them blood because too much of their blood's trapped in their spleen. And then not during their crisis, not while they're sick, you don't do a splenectomy, but once that they're stable and once they're better, then you do a splenectomy, and that's to prevent recurrence of the same thing happening again. Questions about splenic sequestration? No. All right, so here's the summary. Someone has a vaso-occlusive pain event or a sickle cell pain crisis. Very simply, treat their pain. This is the most common reason you'll see a patient in the ED for sickle cell, and is super easy. Just give them pain medicine. Aplastic crisis, remember the association with parvovirus B19. You're likely to see that on a standardized test. Transfuse them if they have symptomatic anemia. Acute chest syndrome, antibiotics, just like you're treating pneumonia. And then transfusion, you do a simple transfusion first, and you'll generally do a simple transfusion for the vast majority of these patients. If they're super sick, then you're going to do an exchange transfusion. Stroke, again, do not give them TPA. You do an exchange transfusion. Anybody have any questions about any of these issues related to sickle cell disease? Nope. All right, that's it then.